take control. Wow, it works. Okay, so that looks good. So if I move it along, that's great. Okay, so fetal genotyping testing. We're going to do a little bit of background information while we're doing it. A little bit of the science, hopefully not too uber geek, but allows you to hang in there. Some of the ethics and benefits of why we're doing these tests. If you want to do them, what are the test requirements? Why is there occasions when we reject samples, which is never a good thing? And then some contact details at the end. Okay, so very quickly, Kath alluded to this earlier, maternal antibodies to red cells can cross the placenta and affect the developing fetus. And the most common antibody found causing the problem is anti-D. So a fairly long time ago now, anti-D prophylaxis was found to suppress maternal sensitization. It was initially introduced at delivery, but then extended to antenatal care. And what it showed, it was a hugely successful clinical intervention in reducing neonatal mortality. So that's a really good thing. But one of the things that always taxed the system was the fact that we knew that a fair percentage of D-negative women would be carrying D-negative babies because of the frequency of the genes. And therefore, they didn't actually really need prophylactic anti-D. But we gave it to them anyway because, certainly antenatally, for a long time, we had no way of determining what the group of that baby was until the time of delivery, when we could then do a group on the cord sample. So this just shows that there was a lot of research and scientific discovery that went into actually looking at how we could take maternal red cell samples and actually test for the fetal blood group. And this all came to a head. And in 2016, we NHSBT were able to offer a service. And in November 2016, NICE produced a paper saying that this was a cost-effective intervention, particularly if it was built into the sort of existing antenatal pathway. So we didn't want to ask women to come back for another blood test if we got it all in the routine sort of pathway. Then actually it was cost effective, and so long as the NHSBT didn't charge too much for it. So just to show you that we've taken that on board. These are the increases in costs, comparing the increase in costs in prophylactic anti-D and the increase in cost in fetal D screening. And the cost of the prophylactic anti-D's gone up about 72% over the last 10 years. And it's gone up 46% for the test. So we're making sure that this stays cost effective. But it isn't all about pounds and pence. Although in this day and age, that is important. What we have seen is a progressive adoption of fetal D screening by English hospitals over the last 6 years, and now the vast majority of hospital sites do refer or in one particular case do the test themselves. And so we're down to now a few rump ends who have not implemented for one reason or another. The NHSBT lab has used continuous improvement to help scale up this new test, which has allowed us to keep the costs relatively under control. Not everything is under our control. And so we currently test over 80% of the English eligible pregnancies. We're aiming for 90%. Within the next 12 months. Both Scotland and Northern Ireland are interested in doing the test and are asking NHSBT to take on the work. And Wales are interested in doing the test, and they're developing their own in-house testing. So fetal genotyping, it optimizes appropriate antenatal care. So the introduction of that screening test allowed us to give prophylactic anti-D only to the women who need it. As a diagnostic test, This is for women who we've missed the boat with. They've already got antibodies, and of course not just to anti-D. And what we want to know is ideally is the baby really at serious risk of hemolytic disease because it's positive for the antigen that the mother's antibody is specificity for. So if we can do that, then we can give the clinical team, obstetric teams, a lot more information that can adjust whether they need to do more or less monitoring, whether they really think that they need to do an intervention. All of these things carry a certain amount of risk, cost, and unpleasantness for the woman. So that's why they are very accurate tests. The fetal D screen is less than 0.1% for false negatives, and sensitive to 99.8%. For fetal C, big C, little c, big E genotypes, we've not been informed of any false results. And for K, which actually comes with its own problems because K is a later developing antigen on fetal red cells, but we still have a very good prediction rate there. So the difference between the two tests with regard to D is the screen is an automated test because we're doing hundreds and hundreds a week. It looks at two specific D exons. It's a sort of low resolution test, and what we give is a positive, negative, or inconclusive. And if we're giving an inconclusive result, then we advise that you treat the woman as if she's carrying potentially a D positive baby. And the test is designed to minimize false negatives. We want to make absolutely sure that we're not going to call a D positive fetus D negative and miss out on that opportunity to protect the woman with prophylactic anti-D. For alloimmunized women, it's a manual test. It looks at more exons. It's higher resolution and can detect some D variants that we might see in some of our ethnically diverse patients. And it's designed to minimize both false negative and false positive results. I'm not going to go through this, but because I think it's all fairly standard care, but it just basically shows, you do your RH typing, your antibody screening, and then you follow an algorithm. Is it D positive? That's fine. We're not going to worry about it. Is it D negative? Okay. Have they got antibodies? No. Okay. Well, we'll just do a fetal D screen at about week 16 to 22. And the reason we put that in is because it depends on the local pathway. We're not saying it has to be done at week 16 or 17. You build it into whatever your pathways are. And then you just follow the algorithm, really. What it allows us to do, certainly for women mothers who already have antibodies, is it means that the clinicians can focus on the women with antigen positive fetus. And it also means if we're able to tell the mother that actually your baby is antigen negative fetus, they can relax and enjoy their pregnancy with minimal monitoring, and that's got to be a good thing. And overall, it saves cost and time for those mothers who don't need the repeated clinical attendance, Doppler scans, referrals for antibody quantifications, titrations, and all those things that we do where we do believe there's a risk to the fetus. Now, anti-D immunoglobulin is an exceptionally safe product. I'm not going to sit here and say, "Oh, you must do it because you're giving a very risky product." It's not a risky product. Since the 70s, we haven't had a single reportable case of infection due to the use of anti-D. They did have a series of hepatitis infections in the Republic of Ireland in the 70s, which has not been repeated. So, we have to accept that it is a human-derived pool product. There may be unknown agents. You can get allergic reactions, but not very often. It is, it does have an efficacy, very high efficacy, when it's given at the correct time. And we have to accept that it has a limited availability. Prophylactic anti-D is made from sensitized male D-negative volunteers. However, the ethics of actually sensitizing a person have become quite difficult, and so the number of donors that are available to actually make this stuff from has been decreasing. So we need to use it only when we actually really need to. So actually using this testing procedure allows us to eliminate donor exposure when a D-negative woman is expecting D-negative baby. And that's an appropriate treatment thing. Samples should be taken when women are being seen for other routine tests. And the clinicians can focus on the women who are expecting RHD positive babies. We want to reduce the concerns over the supply of anti-D or the risks associated with this product. There were a couple of years ago some issues in Germany who were struggling to have enough prophylactic anti-D. We want to reduce the referrals for antibody quantification. It's more testing, it's more cost, it's more inconvenience for the clinical teams and for the lady. So if we can reduce that, it's a good thing. Reduce fetal maternal hemorrhage measurement for women who are having repeated PV bleeds. These have always been very tricky patients to actually decide what you're going to do. You've given them some anti-D, and you've covered the bleed, and then of course they come back and they're still having a bleed. Well, is what we've given them enough? And there are protocols that you can follow, but if you know that the baby is predicted to be D-negative, then you don't have to worry about all of that. And there's a reduced need for cord bloods or bleeding neonates. Again, if you've got a predicted certainly if you've got a predicted D-positive baby, you're treating with prophylactic anti-D. There's no real point in doing the cord blood, because you're going to do or give the prophylactic anti-D anyway. You're going to do the fetal maternal hemorrhage measurement anyway. You don't need to do a group on the cord. Cord blood, it's not that difficult to do, and of course it's not that difficult to collect. But when that gets rejected or it gets forgotten to be sent, who wants to go unnecessarily bleed a neonate? Not the most fun thing that you have to do. Okay, so in terms of sample requirements for the diagnostic tests, so these are for women who have already got an antibody. For RH, it's 16-week gestation. For K, it's a 20-week gestation. And we can repeat at 28 weeks if K negative is indicated. As I say, K is a late developing antigen in fetal development, so presents a little bit more difficulties than the RH. Sample volume is 16 mil. These are samples taken from the mother, just to reiterate that. We want them to reach the blood centre at Filton in Bristol within 3 days of venipuncture for RH and 2 days for K. So suggestion is use first class post, or however you send next day delivery, that's fine. Fetal D screening is 6 mils of EDTA. Anything from 11 to 13 weeks gestation, but as I say, usually we're seeing it built into the pathway, so women will generally be having their booking about that time, and then they'll be sort of like scheduled for other visits for other reasons, and that by that point that the midwife team knows that they're D-negative, and so they can arrange for the fetal D screen to be taken from the mum. And we've got 7 days from venipuncture, and you can use the routine NHS BT transport that visits hospital blood banks every day to move them, and we will ship them around the country at no expense. We have referral forms, and these can be found online, and so they're there, and we also you can find online labels that you can print off and put on the boxes. So that's all pre-printed for you. And again, the same for fetal D screens. For the D screens sampling criteria, it has to be over 11 weeks. You must provide an expected date of delivery, because that's the only identifier for the fetus of this pregnancy. So and each pregnancy has to be screened again because it's a different event. So we must have the EDD, and we will not test if we don't have the EDD. Sample has to be tested within 7 days, and the mother must not have an anti-D or an anti-G or a historical record of these. But we do have the different diagnostic test available to cover those particular women. So we expect the sample to be taken at a routine antenatal visit. The sample can be stored and transported at ambient temperature. There's no reason to keep it cold. We don't retest inconclusive results, and about 4 to 5% of our testing comes back as inconclusive. And we just ask that those pregnancies be treated as if the baby was predicted to be D positive. We have electronic reporting via our SPICE system. And certainly when I was working in hospitals, I gave the doctors and midwives access to SPICE so they could look it up themselves. It's highly accurate, but we will investigate any false negatives that we find. So where we've predicted negative and a subsequent cord or neonatal blood group comes back as positive, we will investigate those to see why that's the case. We have got a new rollout for electronic requesting and reporting, which is now live for Clinisys WIMPATH Enterprise users and also for Epic EPR users. Currently, we have 23 sites live for this, and that says as of January 25. We now have 25. 2 more have come on board, which is great. And this is to try and improve the process. So the original process was everything was handwritten. It went down to the lab. It was checked, and then it came across, and then we had to manually transcribe it in. We would do the test. The result would go out on SPICE, and then that would have to be manually transcribed into the hospital's systems. Whereas the electronic, we can capture all of the patient demographics electronically because it's sent to us. We can then do the test and then report back into the hospital IT systems. So it's quicker, it's more efficient, it's less chance of manual transcription errors. And we are forging ahead with actually this way of doing it, which of course is, if you think about it, is the normal way for hospitals to order tests anyway. Okay, right. So for fetal D screen 1/6 mil collected, you should document the test result in the maternity records, however you wish to do that. But if you have a woman who has got antibodies that you're doing the fetal genotype on, we actually need more blood for that. I'm afraid it's a 16 mils of sample. Here's a few practice points. I'm a lab boy, so I feel a bit uncomfortable in trying to teach clinical people to suck eggs. But again, just to reiterate the EDD and the fact that the samples exist happily at room temperature. And just to give you an idea, this is a sort of pie chart of what we do reject, and no EDD is the biggest thing that causes a problem. And it's another reason why we're really pushing the electronic requesting, because all of that demographic that comes from the clinical IT into the lab IT and then over to us, it captures that automatically, so it doesn't get forgotten, because most often the EDD is missed simply because people are busy. They're human beings, so that's another reason why we're pushing the electronic requesting. But there are some other reasons there as well. But they're all fairly familiar to why labs reject anyway. We do ask for fetal screen samples to arrive as early as possible. We will attempt to make any sample arriving be tested within the 7 days. And if we get something arriving to us at the end of the 7 days, we will fast track it. But if we fast track something, what we're doing then is we're pushing other stuff backwards to allow that to jump the queue. So if at all possible, we like to try and get the samples in good time. We do work at Filton on Saturdays, processing and testing, just to try and make sure that this process flows as much as possible. But we do accept that you've got samples often coming from the community. NHSB logistics. I worked up in the northeast, and if we sent these fetal descreening samples to Newcastle, it would take 3 days to get down to Bristol. So over Christmas, we would have to do some sort of calculations on our fingers and say, right, we're going to have to stop taking those samples, on this day, and then we'll restart them on, after the holidays, because we can't keep taking them right up until until Christmas Day because of the transport. So you just got to bear that in mind, really. EDD, this is a message that is pushed so much because it is so frustrating to reject a sample simply because the EDD is there, but it's the only way that we can identify that pregnancy. We do have a question and answer document on our website. And so, please use that. Here are some contact details. Erica Rutherford, who's my colleague, who has been instrumental over the last few years in driving participation in fetal descreening. She is retiring at the end of May, but she would be happy to take any questions up until then. But the Molecular Diagnostics Laboratory at Filton, which is where the test is done, has an email address which is there. There is also the website and a QR code if you wish, which has a lot more information. As I say, the vast majority of hospitals are now sending to us, and I know that actually Cambridge are using the electronic requesting and reporting. So they're one of our leading hospitals in implementation, which is really great. And with that, I think, any questions?